So good afternoon and welcome. My name is Bleddyn Rees. I'm the chair of the Digital Health Society and the deputy chair of the European Connected Health Alliance. So a couple of housekeeping announcements. So first of all, I always like to know who's in the audience. So please put your hand up if you're a clinician. Okay, reasonable number. Put your hand up if you are a CIO or IT director. Ooh, very few. Okay. Put your hand up if you're industry. Okay, so the vast majority of the room. Okay, so who are we? So in the next couple of hours, you're going to hear from myself and some colleagues, and we will explain who the ECHAlliance is, who the Digital Health Society is, and what we do. But very simply, we are transforming health and care globally. So in a way that tech is global, medtech is global, pharma is global, healthcare is national. We believe that is the root of much evil, that it explains why you have variation in quality, it explains why so many healthcare systems are unsustainable. So we have four things that we do principally. We connect, we convene, we amplify, and we accelerate. And you'll learn more about that during the course of this session. We're a membership organization. We're a not-for-profit organization. So the shameless appeal to join us if you like what we're doing, get involved. We need people, organizations, we need to match needs and solutions. You'll see on the table that there is an agenda with a little bit of information about what we do as a takeaway. There are also some business cards from Carolina and myself. There's only a handful there, so if there aren't any, please come and see us afterwards. You'll see there's a bowl. Where's the bowl now? Okay, it's by the camera, and the bowl is for people who are interested in what we're doing and want to leave their business cards, so please do that. And without boring you any longer at all, I'm going to hand over to Carolina for the first presentation. Thank you.
Thank you, Bleddyn, and good afternoon, everyone. My name is Karolina Mackiewicz. I'm the Innovation Director at the ECHAlliance, European Connected Health Alliance, and we are hosting this event today under... There is a bit of an echo?
Yeah.
Okay. We're hosting this event today under the our initiative, Global Health Connector Partnership, so to get out from Europe to connect the organizations from the other parts of the world, but we will also explain a bit more about this during the course of this event today. So let me just... How do I make it work?
Green.
Yes, green. I'm pressing green. All right. So yes, this event today is this 2 hours. We'll speak about the international and global opportunities in healthcare and how also you can get involved. What is there in for you? So we have the first block where me, John, and Bleddyn, we will tell you a bit more, like crash course on our initiatives and what we are doing and what is in there for you. So let me start on the ECHAlliance. Who are we? As Bleddyn said, we want to connect needs and solutions. So we are the global connector for digital health. This is our mission, to connect people, to connect businesses, to connect people from the different sectors and making sure that you guys know about each other and you are able to develop better solutions that then find the buyers and find also the funding and can be actually roll out to the market and serve the people. So we are in principle membership organization. We have the organizations coming from all sectors, from academia, from government, from business and society organizations. We connect currently more than 22,000 individuals from all parts of the world, and we are the community interest company registered in Ireland and in the UK. So I will say more like what we do. Like Bledin already said that we connect, we convene, like today. We amplify the messages from our members, our ecosystems, and we help accelerate the business and the change management. You can become the member of the ECHAlliance for multiple reasons, and there is many benefits from being our member. Of course, like growing your network, making sure that you have good connections in the industry, in the area. But also access our ecosystems. I will tell you more what our ecosystems are. And of course, get to our events like this one, or Health in Las Vegas, or the other events in Europe, in India, in Africa. And there is plenty more, of course, opportunities where you can also promote your organization. You can also get a speaking slot at our events and make sure that people know about you and recognize you. This is what we do. What are our ecosystems? So we roll out the ecosystems already 10 years ago, and currently, at least in Europe, everyone is talking about working in an ecosystem, making sure that you're bringing together our different stakeholders together for more sustainable development, for more sustainable work in different areas, including digital health or healthcare as such. So we want to bring together we promote the ecosystem methodology and bringing together the academia again, companies, health and social care, government agencies, patient groups, network and associations. And on this slide, you can also see how many members from different sectors representing those sectors we have. So we bring together the different stakeholders and we make sure that they work together. And as you see, matching need and solution, breaking down silos, and by this, transforming the delivery of healthcare, and of course, making sure that we create economic growth on the regional level, organizational level. Just one word to all those people who just came. There is still a couple of seats here under the tables in front, so don't be shy, get your seat. We are happy to have you here. And still so if you would like to know, like, okay, so what about those ecosystems, how many they are, what they do, where are they located? Here is like the small visual showing you the ecosystems. You can see that most of them are hosted by the regions. Some of them are also like on the level of the country, or in, for example, in case of Africa, it's even wider scope and the coverage. And they are often hosted by the innovation agencies, universities of applied science, clusters, and they are part of our wide ecosystem global network, so also connecting across the countries, across the borders, across the continents. And also we started working on the thematic innovation ecosystem, something you might think about in terms of thematic working group, where we focus on specific topics, like, for example, skills for health or digital health data, life sciences. And those ecosystems are very, very inclusive because they happen online. So the meetings of those ecosystems are online. So the best way to get involved is to follow our social media and pop up at one of those events to learn what are those events about, and also in the future to become our member and be a speaker. And we also engage in a number of the R&D projects where we support those projects with the exploitation services, communication and dissemination services, and I will explain a bit more about the different opportunities in that area in the next block of today's event. So we have a number, currently we're engaged in more than 10 projects, international multi-stakeholder projects on different teams, ranging from digital health data and policies to skill for health and care workforce, smart and healthy living, or digital health and care support tools in general. So also you can follow us for that. And last but not least, we have another initiative under the ECHAlliance group called Digital Health Society, which is chaired by Bledin. And this is our initiative that focuses solely on the health data, primary, secondary use of data sharing, data management, data generation, and all those issues related to data. So I'm sure that many of you are working with this team, with this topic. I represent the company that deals with health data, and we are the organization that connects for sharing, reflecting, and mobilizing. And of course, in the EU, we have now an exciting process of rolling out soon, hopefully, or getting the new legislation on the so-called European health data space. Bledin will explain a bit more what does it mean also for the companies coming from outside of the EU for your business. And maybe then going global, like speaking more on the Global Health Connector Partnership. So here I would like to invite John, my colleague John Werner, to tell you more about the opportunities coming from the Global Health Connector Partnership. So maybe John will also say a couple of words about himself and why he's here. Thank you.
There's still some seats at the front for those of you standing at the back. So
please come here.
There's a couple down
5 here, 2, yeah.
5 here, a couple over there. So if anyone wants to just wander down, there's space. Thank you, Carolina. So we just advance the slides one by one with the green, I guess.
Yes.
So just to continue what Carolina has said to you, Global Health Connected Partnership as part of ECHAlliance is obviously global in its nature. And in fact, our attempt is to, at a much bigger picture level, connect best practice in places such as Canada, and the US for that matter. We'll come back to the US on the end. Africa, India, Europe, Latin America, Australasia generally, the Commonwealth countries as were. And in the US, I'm an ambassador for ECH here in the US. We would love the ecosystem to be even bigger than it is. I feel with this action, I live in California and have done for the last 20 years. But one of the things I find is that we don't share best practice well enough inside the States, let alone internationally. And I think we can benefit from that greatly by having this mechanism to put people together and discuss how far they've got. There's some really incredible best practice all over the world. Just in terms of how this organization runs, Brian O'Connor is the chairman of the Global Health Connected Partnership, but there's a whole set of council members that come from multiple places around the world and guide the efforts in a number of realms, and not just the ones you see here represented at the bottom. And we look at big issues that we think are truly international. Disparities being one of them. We know we have a lot of talk here locally around health equity and access and disparities, but there's some good practice going on we can learn from. I think skills is another big area, and digital skills in particular, and who's got best practice around educating people in those areas. Digital health services, meaning the wraparound around the technology that we're deploying. And do we have the services in place to make those work and work well? And last but not least, maybe one we don't hear enough about here in the US, in my opinion, which is green health. We're something like I think healthcare around the world is responsible for about 5% of emissions. It's as much as airlines, for example, which gets talked about a lot, but we don't necessarily talk about it. And there's a lot we can do to be much more sustainable in our practices. We have been obviously doing a lot of work in those individual places that I had on the first chart. And some of these ecosystems are interesting in and of themselves. This is an example of a symposium coming up in June in Johannesburg, which is the role of the private sector in Africa's new public health order. And that's both an outbound and an inbound opportunity. Africa is a very big set of countries, nearly 50 countries, that have got their own challenges. In some cases, they're ahead of us in places like Kenya. Their mobile phone penetration is greater than it is here in the US. And in rural populations, they're serving healthcare in ways that we can't even imagine. So some of that technology thinking can be inbound to help us think about issues in different ways, and outbound to that market where they are pretty hungry for best practice as we would have it here inside the US. And I think this might be last, but if it's not, don't forget to save the date also for the other side of this conference. ViVE, as you know, is part of a two-step for the health organization. This conference runs this time of year, and then the one in Las Vegas runs in October. We'll be there in force. We'll have quite a lot of people. There'll be other events going on, and we'll be showcasing some of the members and some of the best practice that is going on around the world. Carolina, is that the last slide in this set?
One more.
One more. And not to forget also later in the year in November, the Digital Health Society Summit, which is coming up in November. I think you can join that both by Zoom, virtually. In fact, it's all virtually, I think, in that case, isn't it? Another wonderful opportunity to hear best practice from a whole group of people that are practically deploying it, not just talking about it. We had some conversation yesterday about Estonia, for example, and what they've done. Some of you may know their use of blockchain in healthcare has just been incredible. My favorite stat from Estonia is the last time they ran an election, admittedly in a small population, it took them 20 minutes to run the election for the whole country. I think some of you who live here might sort of welcome that as something we might do here. So with that, I will hand over to my colleague, Bleathen.
John, thanks.
Sure.
Back on? Right, okay. So while the Digital Health Society Summit's up, the very first one, it's all about thought leadership. The very first one was 125 people in Finland as part of the Finnish presidency of the European Union. Last year, we had 1,000 registrations from 95 countries triggered by the pandemic. So suddenly we started finding for our thematic ecosystems that we were having South Americans turn up at Spanish ecosystem meetings. We just never envisaged that. It was just one of the benefits. So strap yourself in. So quick couple of slides. So the first thing I don't like about technology is it's been over-promising to healthcare and to clinicians for a long time. And this was the radio doctor in 1924. And I just use that as an illustration of the point I've just made. So this was 10 years ago, a quote that I'm sure all of you have seen, probably still as true today, if not more true than when he actually said it. And I'm trying to paint a picture for what the Digital Health Society does in terms of digital and data. So this is a Gartner slide that, the trough of disillusionment that I'm sure many of you have seen, if not, are engaged in and working in, so to speak. And this one I particularly like, the pace of adoption to 50 million users for various types of technology, and then just think of healthcare. So my son is just totally frustrated that he is not unable in the NHS to actually book his appointment with a GP online, talk to his GP online, get his drug prescription online. And despite whatever the NHS says, and I know there's a few people in the room who are there, the actual experience of individuals leaves a lot to be desired. We run the Digital Health and Wellness Summit at something called Mobile World Capital, 100,000 people in Barcelona every year for the telecoms industry. And there was a blind expert in telecoms who put this up one year when we took him. And so those of you of a certain age will remember the $6 million man, who today would cost 100,000, except that was about 5 years ago when these slides were created. And it just shows the difference that you have with some of the technology. But moving on and looking at how is health data being generated, how is it being generated? So for those of you interested in soccer in this part of the world, Barcelona is one of the teams in the world. And Barcelona has I think it's 12 professional sports. It's not just football. And 7, 8 years ago, they've effectively got a mini hospital. They're looking after their professional players. But what's really impressive is they've got an innovation hub. So they are using a battery of sensors around their professional athletes. How do you keep Lionel Messi on the pitch without a hamstring injury? How do you ensure if he gets a hamstring injury, how fast can he recover? So that innovation knows no boundaries. And in particular, much innovation is outside of healthcare. Another example is which industry knows the most about remote monitoring? Well, I'll give you a clue, it's not health. So 8 years ago, we took Shell to Mobile World Capital to, for the first time ever, publicly explain what they do. So energy companies own the most number of ships in the world. And people have been getting ill on ships for centuries, so producing data. So energy companies are very data-centric. So basically, they had the first supply of Google Glasses, $30,000 of satellite equipment in a briefcase, workers in remote parts of the world that they can't helivac out in 24 hours, and as a consequence, they have to treat them in situ, can't get doctors or nurses to work in those locations. And it's just fascinating that they have this data, and to my knowledge, no health system is actually tapping into it and what they've learned. And they also take the same approach to their workers in offices in terms of collecting data in the workplace. So back to the blind telecoms expert who started to talk about digitally enabled and enhanced people with disabilities, and just painting a different picture of what innovation can look like in healthcare. And one of our members is McKinsey's, so these are some of their slides, and a guy called Tobias Silberman, who runs their health tech network, which is about currently 1,700 digital health startups, friends of the network, which is showing innovation around the world. So we're big supporters of the health tech network in terms of where is this innovation, trying to help it promote it. So for those of you out there who are in this space and want to know how do you promote yourself, this is one of the ways of getting involved. And then Tobias was then talking about health data for a business and looking at 4 main customer types. And I'm not going to go through these, but just to see the sort of analysis that he was making around biopharma, payers, providers, and citizens and ecosystems. And then starting to categorize the health data. And this is something where you hear a lot of people talk about health data, but you're not necessarily sure what type of data they're talking about. And this, again, is just giving you an example of that sort of analysis and how we promote knowledge and information about this area. And then he started to actually go a next stage further about looking on the use cases. And moving us along then, Qualcomm were at Barcelona at the Mobile World Capital last month, and they started talking about the power of on-device AI. And I think these slides build, so I'm going to just show you. So this concept of my health, and more to the point, how many everyday occurrences there are in terms of connections for wireless devices, and just the scale of opportunity that exists. And then a glimpse of the future from Qualcomm, and I particularly like this slide, starting to show you all of the sensors in a pair of glasses and starting to understand how do you empower people who might be deaf, might have eyesight problems, might have gait problems, and the potential for sensors to transform well-being, prevention, and healthcare services. So I always like, this is a very old slide of mine, where some things sound too good and you're worried that it's delusional. Well, I don't think digital health is delusional. I think it's very real. And with that, I'm going to hand back to Carolina.
Thank you so much, Bledin, for this introduction. And now I would like to maybe tell you a bit more about the opportunities coming from the participation or engaging with some of the R&D projects that we as ECHAlliance are partner with. I don't know if any of you or how many of you have heard about the Horizon projects financed by the European Union. Do you have the knowledge about the grant scheme of the European Union called Horizon? No? Yes? Someone? Okay. So if you raise your hand, how many in the room? No? Okay. So some of you know. How many of the organizations are part of the project and the finance project? None? Okay, so maybe I will just I will not give you the whole explanation what the Horizon is, but this is one of the, if not the biggest R&D program in the world. And of course, there is a lot of different topics under it, all that matter for the development and for the research. But there is a good chunk of money every 7 years when the EU budget is decided, of course, directed to health. And obviously, digital health is the theme. Like there is, so every 2 years there is a work program being published with different calls, which are being open with a specific deadline. And every project should be multi-stakeholder, like bringing together all those partners from the ecosystem that I told you about, and also being built across the countries. And actually, like maybe not all, but in many of those projects, now also the US or Canadian and other companies can participate. So it's also good to stay connected with us or inform yourself about this and be partner of one of those R&D projects. But what we do, like I already showed you also the how many different projects we have on the different teams, but why we as ECHAlliance we engage in those projects. So now you know that we are membership organization bringing together a vast community of experts, over 1,000 member organizations, and of course there is a lot of knowledge and a lot of thought leadership and a lot of material being produced by all those members. And we in the innovation team, we want to support our members in getting in the good quality consortia to develop their research further, to develop their innovation further, but at the same time also bring the knowledge about the innovations and about what's going on in the R&D sphere in the EU and in the world to our members. So this is why we engage in those projects as a partner, to see, to observe, to have it firsthand, and to also bring it back to our community. So I already showed this to you. So different topics. Some of making sure that actually supporting the regions, supporting the countries to be able to take up the digital solutions that are being developed. Also matching the buyers and the sellers, as we call it, bringing together the partners from the demand and supply side so that they know about each other, and of course also helping develop the different digital tools that then should help us transform healthcare. And I choose here for this presentation 4 projects that with very big scope and scale to show you some of those opportunities. And Gravitate Health Project, this is actually the project that runs for, now it's in the 3rd year, it's a 5-year project, it's the public-private partnership run also with the Pfizer. And it's on the bringing together the electronic product information to make sure that every patient in every of the 27 countries of the EU and also other countries in Europe has access to their product information regardless of where they currently are, and also can realize their e-prescription when they are traveling, and can have also access to support from the healthcare practitioner. And so, as you see also in the long title, that's empowering and equipping Europeans with health information for active personal health management and adherence to treatment. As you can imagine, there is a lot of work here going on interoperability issues and data issues, and of course the regulatory and standardization issues. And one of the opportunities to engage is the hackathon that will be organized in May. It's in Stockholm at one of the biggest conferences, but it will also have an online edition, or it's a hybrid format, so you can also get connected. If you work with standards, another opportunity for you is to get connected through so-called connectathons, so that actually they run every 3 years, and you can also then bring your view, bring your solution, and get informed of what's going on and how to actually work on standards in order to have access to the European market. And if you would be, for example, interested to work more on advisory board and still observe but give your input, there is also an opportunity through the International Advisory Board. And yeah, here is the word on the hackathon. So that's the first hackathon coming quite soon, and we will have the challenges published probably next week. So stay tuned and follow. Then there is the brain teaser. That's a different project, and that's on working on data and then bringing the AI solution and exploring the AI for better care of the patients with LAS and MS. And also, as you can see, there is a lot of work being done through the open science approach, so to also bringing the different companies, different stakeholders together to actually work on the data sets that are being provided by the projects, and to help evaluate the challenge, to help solve the challenges. So this is also something that where you could potentially be engaged, and also then, as you see, producing data on according to the FAIR principles, which stands for findable, accessible, interoperable, and reusable. This is also something where you could potentially benefit from those data sets, of course, under the certain and strict rules of obtaining them to accelerate your business. And then, again, very different project. We are engaged as ECHAlliance as the leader of so-called preparatory action that will inform the European Commission for on the opportunities and the future of digital health. And for that, we run a number of the so-called futures workshops to explore the different scenarios of digital health and to explore the probable and preferred futures. And here on this very simplified slide and this visual, we explore the different uncertainties. And as you see, we decided that the two big uncertainties in the area of digital health are policies. Will they be enabling policies? And empowerment of people. Will people actually feel empowered to have access to their data and manage their health with the digital devices? And our time frame for this exercise was 2030, so in 7 years. And then, well, of course, we have a lot of different promises when it comes to the policies, I think. Same as here, also at home in the EU, we have the data strategy and then the different policies, also this European health data space. But those are yet promises, and we don't know if they will be realized. And at the same time, of course, we see a lot of interest from people to engage with digital health, but there is still a lot of inequalities, and we want to cover more and more population. But coming back to what is the preferred, so all those futures are probable, right? Digital health is health, it's a limbo, the black hole, or the status quo. but which one is the preferred? And we run a couple of the consultations with the different stakeholders, and of course everyone says like, yeah, digital health is health. So here we have wide internet coverage. We have people who are aware that they have this opportunity to manage their health. We have good policies. We actually have also the good reimbursement schemes for the different telehealth practices and the digital therapies. And but to make this happen, we actually have to work together on the different levels and engage with the different stakeholders, which we try to do. And also one thing on the, we mentioned a couple of times today, the Skills for Health team or empowering and skilling, reskilling and upskilling healthcare workforce. I'm sure that this is also very relevant for you guys, and many of you probably work with the doctors, with the nurses and different healthcare workforce. So I wanted to let you know that also there is a big initiative going on right now on developing the European strategy on digital and green skills. So also the green health, decarbonizing healthcare, making sure that healthcare is sustainable. And the first version of the strategy should be available for consultation in June this year. And why this matters? It matters because, of course, there is the big focus on, again, skilling, reskilling, and upskilling in the European Union, making sure that our healthcare workforce knows about digital health. And obviously, there is also a lot of different solutions coming up that we actually have to train our healthcare professionals on them. And in this particular project, we also try to explore what will be or anticipate what will be the future occupations in the area of healthcare. So what other, like now we of course know that we need data specialists, data analysts, we need people who know about AI. But what else? What else is coming until, again, 2030 or beyond that, and how to actually organize this? And perhaps this will be very interesting for you and could also inform you, inform your businesses, inform your organization, and maybe at the same time inspirational. So that's why I brought this example to show you that this is happening. And there is also so-called the Pact for Skills for Health ecosystem. So there is also the big partnership being formed around this to make sure that this is actually a reality, that this is not one of those strategies that is only on the shelf. So I invite you to follow, to stay connected. If you follow us, ECHAlliance, on social media or subscribe to our newsletter, you will also know about those projects because we publish information about the results and what's going on. And we also try to bring the information during the events like this. But then there is also a couple of my business cards on the table. So if you would like to know more on get engaged in general or get engaged in one of those particular initiatives, then just let me know. Let's connect on LinkedIn and stay in touch. So I hope that this was informative and inspirational. And for the other part of information and inspiration, I will then hand to Bledin, who will say a bit more on this European health data space and what does it mean for all of us. Thank you.
For those who don't know me, by background, I'm an international healthcare lawyer. And this is one of those rare occasions when you get to understand why lawyers and alligators, what they have in common. So normally close proximity to either costs you an arm and a leg. This is not one of those occasions since I'm not being paid. So looking a bit about international opportunities in healthcare and how to get involved. So the focus for the next few slides is very much about European laws. And the reason for that is that there's something called the Brussels effect, where the European Union legislates, and then the rest of the world, excluding America, is likely to follow the direction of that regulation. And in a digital single market around the world, if you have a digital solution, you want to sell it everywhere you can, the relevance becomes how universal that solution can be in terms of compliance. I believe, as you would expect a lawyer, that regulation is a force for good, and that indeed the power of the law to enable better healthcare is substantial. So, a little bit about what I'm going to talk about. So, what's happening in health data in Europe? Why is it important for digital health? And then the new and potential EU compliance requirements. And this is not about trying to frighten you about what you're going to have to comply with, quite the reverse. The intention with the European Commission is to facilitate more innovation, better business opportunities for in digital health, full stop. So this is about better and business opportunities for anyone involved in the delivery of healthcare. So picking up that theme, that this is not about frightening you. You don't need to be worried about having to have lawyers with you alongside to try and navigate what I'm about to show you. And it's not about scaring you, as I've said. It is about this great opportunity. So a strange place to start. What is healthcare? So in the European Connected Health Alliance, the diagram that you can see on the slide is taken from Northern Ireland with a simple visual explanation of what various healthcare services are. But in the Alliance, we believe much more that it's a combination of health services, social care services, which, for those of you not familiar with that term, is about care for the elderly, care for the disabled, and also around prevention and wellness. Well-being services you can see, but then really importantly, housing and education. So we are only going to keep people well if we build health literacy, we build digital literacy, and housing is a key determinant of health. So for us, it is about the definition that WHO created, which, if you read it, is a state of complete physical and mental and social well-being, not merely the absence of disease or infirmity. The problem for all of us is that WHO has spent almost all of its time tackling disease, not really tackling either mental health, let alone prevention and well-being. So as part of our ecosystems, we are very focused on this definition of what we think of as health. So, the background then to the various legislation I'm about to not so much summarize, more signpost, okay? I'm not trying to explain all of this legislation. It's too extensive, and we simply do not have time. But the thing to understand is that the European Union has no power to harmonize health laws in Europe. Health laws are the sole prerogative of member states. So that means that the health laws in the 27 countries are all different, may have some overlap, but if you're trying to do business in those 27, you almost need to understand what are the rules in each of the 27 countries. In contrast, the European Union has power to harmonize laws around such things as the digital single market and consumer rights. And that manifests itself in GDPR, the General Data Protection Regulation, and such things as CE marking. So that's the contrast that you need to understand in terms of generally Europe. And then I just put at the bottom, why is this so important? What is it about health data? And obviously it's about patient safety, quality of services. It is about the development of new health and care services and products. It is at the heart of academic research, understanding, policy and innovation, and about whole population management and sustainable healthcare systems. So what is this legislation? Why am I rabbiting on so much? Well, that's because there are 8 substantive pieces of law which the European Union's been working on in the last few years and is still working on. And the scale of this is very, very substantial. And I'll touch on each of them in the next few slides. But what I really wanted to say was, this is about, in Europe, fundamental rights, and the European Union protecting fundamental rights of European citizens. And the problem is that there is a distrust of American tech, whether it's Microsoft, Amazon, Google, Apple, made only worse by such things as hacking Merkel's then German president's mobile. So there is a disproportionate anxiety, I think, sometimes about this topic, but it is the real world. In contrast, the US position is that it doesn't want to use law to stifle innovation. And those two positions are actually quite two ends of the spectrum, okay? So this is going to play out over my lifetime. So it's not going to be resolved next year or the year after. And there may well be different results in relation to different pieces of legislation. So the first one, the Digital Markets Act, which is now in force. And this is not a specific health law. It is a multi-sector law. And it's really about competition regulation. So antitrust in this market. And it's about behavioral rules, which are quite detailed, 22 do's and don'ts. And it's extraterritorial, meaning the EU is legislating against US companies who do business in Europe. So you don't get off if you're just an American business thinking you don't have to comply. Lots of Europeans think this is payback for how antitrust laws work in the US that catch non-US companies and countries. So this is, if you like, the European Commission reciprocating. And the important thing here is gatekeepers, okay? And gatekeepers are defined as businesses that have 7.5 billion euros business per annum in Europe. So this is not startups, SMEs, small businesses. Or they have to have a market cap of 75 billion euros. So you're getting to the Microsofts, the Googles, the Amazons, the Apples, not startups. And the expectation is that this will alter the business models of those gatekeepers. But it'll be some years before we see what the true impact of some of this is. Next one, the Data Governance Act, which is really about such things as interoperability and how you share data. And it's a set of rules, processes, and technical means to facilitate data sharing. And it's about a level playing field, simply, for access to data and ensuring that the rules around GDPR are adhered to, so privacy and security. Then looking at the Digital Services Act, this is, again, mostly enforced, sometimes labeled by commentaries as the Constitution of the Internet. So a very significant piece of legislation, and about, again, promoting in different ways fair competition on the internet for digital services. And the rules are very much graded depending on whether you're an intermediary, whether you're hosting services, whether you're an online platform or a very large platform or search engines. So you can see again how this will impact many of the very largest US tech companies. And the controversial part of this is about regulating what's called illegal content. So the protection of user rights and liabilities. And at the moment in the United Kingdom, there are lots of issues around misogyny, around grooming of children, which this content comes in, and how fast that content is removed from the internet. So this is a significant piece of legislation. And what the European Commission are doing is they are harmonizing the legal framework across the 27 member states. So then the Data Act is really about, again, making industrial data available to a wide sources. So think of connected cars, industrial sensors, smart households. So what sort of data? So if you think of automobiles, think of steering wheels, sensors in a steering wheel predicting or measuring your heart rate, then using analytics to actually, and predictive analytics to work out that you may have AF. In the United Kingdom, there was a real tragedy one Christmas when a bin lorry, a refuge lorry, plowed into a family at Christmas time, killing, I think, mother and maybe 2 children. and the driver had AF, knew he had AF. Well, if the steering wheel had sensors, it could have actually disabled the vehicle. So you can see how there are potential applications for this. But this is then about making this type of data available to researchers and to companies who are trying to produce innovation. So it facilitates competition between cloud and edge services as well. Again, extraterritorial. So then turning to artificial AI. So this is one of the really interesting and incredibly complex pieces of legislation. So it's the first piece of legislation looking at AI anywhere in the world. It's very important for healthcare. So it has things like trying to define AI, and then it's trying to grade it between uses that are non-threatening, uses that have low risk, medium risk effectively, high risk, and prohibited. And we've been running round tables on some of this, and it is complex. It's complex from a clinical perspective, and you get into distinctions between AI models and AI services. So the services, just for this purpose, is where human beings are involved in the process. So they might be involved in the data sets, deciding what the parameters of the data sets are. They might be involved in curating that data before there's any model development, and then involved in interpreting the analysis that from the model and deciding whether treatment stays or doesn't stay. So watch this space. This may take a number of years before this legislation actually becomes law. And then something about new product liability in the AI liability directives. So essentially, what the European Commission is doing is taking its existing strict liability for products and saying smart technologies will have strict liability. And then it's saying under AI, it's making it easier for consumers who've been harmed by AI to bring fault litigation against those who are responsible for putting it into the market. So for lots of organizations, the business model, a key part of it is the risk associated with it and the risk management, which affects price. So this is in the melting pot around what's going to be happening over the next few years. And until we have much better understanding of health use cases, it's going to be difficult to know how this is going to work. So if you thought of mature health cases, you'd be looking at radiology. But most other applications are still in early infancy in terms of how they're used. So the next one, the biggie, the European health data space. So this is the thing that the Commission have been talking about for 4 or 5 years. The idea that in Europe, we effectively will allow health records from all of the member states to be available to researchers for secondary use, as well as available for primary use across borders. And this has excited a great many people, whether it's researchers, industry having access to this data. And if you were trying to do AI, for example, you really struggle to get hold of quality data in volume in order to be able to carry out assessments. So without saying too much about this is a really important piece of legislation and really at the heart of trust, and then things like cybersecurity, privacy, GDPR. And we have done a lot of work on this. A little bit I'll tell you about more in a second. So to round off some of the stuff about this, the real problem as a lawyer here is the consistency between the legislation list that I gave you. And lots of lawyers are genuinely concerned that how GDPR fits in with this is unclear, and whether we're going to have 2 sets of rules or even 3 sets of rules. So also then there's the consistency, and the problem around Europe is the interpretation in different countries. So this is not straightforward. However, what the European Commission is doing is laudable. It is genuinely trying to facilitate digital health. So whilst it's easy to pick holes and criticize parts of this, it's actually a very brave, forward-thinking set of laws. And then the last thing about legal costs and damages is in Europe, we're much easier to actually innovate because we don't have anything like the American-style damages. We don't have anything like the American-style costs of litigation and how much you pay your lawyers. Lawyers aren't poor in Europe, but they're not as wealthy as some of them are in the US. So actually there is a significant difference here between risk. So in my professional life, dealing with US lawyers around healthcare, I found infinitely harder than anywhere else in the world because they're risk averse because of the damages exposure and the costs. It's just one of the facts. And for those involved in digital health, it's just one of the things that you have to navigate. So moving along quickly, so to stay on time, I'm not going to talk much about the eHealth stakeholders group, except to say that it supports the European health data space. And I'm going to say a little bit about calls to action. So one of the other things that the Digital Health Society has done is it looks at the thought leadership. So we had sponsorship from Microsoft, J&J, and MSD to try and produce thought leadership to promote the development by the Commission of the European health data space. This led to 6 conclusions that we published in a report, which were looking at what we thought were the key enablers of the development of the European health data space. So you can see those for yourself. And subsequently, we ran another 5 roundtables, and the roundtable format was 25 to 40 experts taken from all stakeholders, regulators, ministries, industry, academics, to deep dive into each of these. And they're all published online. There's the QR code. I think you've got the QR code. No, you don't, on the tables and the leaflets, but we can give you that. So you can go and see what those conclusions were and how some of the issues have been tackled. So there's a few of you taking photographs, so I'll leave it there for another couple of seconds. And then we're going to move now, and that brings me to a conclusion. We're going to move to the next session, which should have been with Professor Martin Curley, but unfortunately on Friday he became ill. So we're going to use a few of his slides, which John is going to talk to very briefly. And whilst he comes up, do many of you know, put your hand up if you've heard of shift left, stay left. Okay, hardly any of you. So this is a bit about, okay, how do you move from an illness system to a prevention and well-being system? So with that, John, I'll hand over to you.
Thank you. Do it that way. Okay, thank you, Blevin. Martin would do clearly a better job than I'm about to do in terms of running his slides, so I hope I can do them at least some justice as we go through these. This is a really interesting initiative, and as you'll see, embedded in the United Nations in terms of where the initiative originally came from. We'll get there in a second. Just for some backgrounds, we know all of us who have lived through some very challenging times in certainly the last few years, and particularly turbocharged by the pandemic and everything that's happened with it. And we might argue all over the world, healthcare has had to cope with that, and parts of it are in crisis. And they're in crisis for a whole bunch of different reasons, not the least of which is that we have many of the clinicians are burned out, overworked. We have now shortages because we've had so many leave the profession, for example. We've seen actual cuts in some cases because funding, some of the extra work that's been needed, has been difficult for governments to do and align in terms of need. So these headlines aren't going to go away anytime soon. And we need a different approach. We need to think differently, and I think we've been catalyzed to do that, and I think we've seen some of that, but we're going to see a lot more. These are just a few more headlines that you can see all over Europe and all over the States where I am. collapsing systems, consolidations of organizations. We've seen all sorts of change in our local marketplaces, as we all know, and so on. I'm just going to, that last one, hospital turnover. It's now estimated we're going to see every hospital system in the United States entirely turn over every 5 years its staff. That's just incredible. Can you imagine the legacy knowledge that's lost in a 5-year time frame? That's gone away. That's of the past, where we would have had 10, 15 years worth of legacy knowledge. We now are down to 5 years. So what this initiative is all about, and it's part of the Sustainable Development Goals that the United Nations have had together, and there are many of them in that chart at the top right you can see on that chart. This initiative is about good health and well-being. It's initiative number 3. And as Blevan said, it's stay left, shift left, and 10x, and at least briefly I'm going to explain what that means. It's just a nice catchy phrase. That is Martin Curley sitting on that slide, so you can see who would have been here rather than me trying to do a poor substitute. We all know that determinants of health don't just come from dealing with sickness, of course. We know the picture, it goes even more broadly than this, but behavioral patterns drive, it is estimated, about 40% of our problems we encounter in life throughout our life. So they're not specifically health related or sick care related in the first place. It's our behavior that we adopt throughout our life from cradle to grave. It comes from our genetic disposition, something we're starting to get a grip on, but very late in the day. So can we make greater use of that? Starts to become part of what we're talking about. It becomes, it's also parts of our social circumstances. Literally the extent to which we have relationships and can be supportive around it. I mean, Blevan talked earlier about social care, but this is about social connection. That's another 15%. And then medical care comes in at 10%. So the quality of care we get medically is 1/10 of a determinant of our overall capacity to thrive, you might say. And then 5% that's left is environmental issues, sometimes which are invisible to us, but maybe we're not managing either. Toxins or particulates in the atmosphere and those sorts of things. We talked about green health, for example, as part of that. So our spending, unfortunately, doesn't reflect this. Our spending has actually been on the sick care component and is heavily around that 10% of medical care that we render. We wait for people to get sick and then we render care. And some of us who work in that field know that to be true, but we're not getting upstream of that as an issue. These numbers come from Ireland, and you can see also come from Europe in the blue bars, and they're very similar. Martin's based in Ireland, so he's got a lot of data, and Ireland's been something of a leader in this space. But you can see that played out just in terms of where we spend that money. And it's true here in the US as well. In fact, the numbers are pretty easy to get here for the US, and they are very similar. So inpatient care dominates, outpatient care is second, long-term care is third, pharmaceuticals and medical devices are fourth on there. Ours are slightly higher in this country. Some of you will know drug costs alone are about 15% over here, and you add devices into it, we're well over 20%. But look at prevention on the far right. That's really what we're trying to address. We're trying to address the spend. In Europe, it's 2.7%. It's estimated it's 3.1 here in the US. It's a tiny, tiny proportion of how we spend our $4.2 trillion, I think, in 22. Not that we've seen the figures in detail yet, but that's the size of the pie that we're spending in that way. So what we are fundamentally trying to do is try and use open innovation, and it's open innovation which has been around now for 50 years, but the 2.0 version of this, in the collaborative way that we've talked about it in prior comments that Carolina and Blevan have made, to leapfrog our way forward into a better approach. And fundamentally it means building high trust capability and relationships, and not just locally, but on a national scale and then an international scale. Where is best practice? How do we find it? How do we leverage it so we can go faster in terms of what we do? And that means we need intense networking, much more than we have. We have to have more conversations in rooms, in ecosystem conversations, and it's really what we're all about. So these are not just show and tells, they catalyze conversation. So we hope as many of you afterwards can stay around for the Q&A, because it's, knowledge in this room is much greater than knowledge that you see up on this stage. It's then about a shared vision, and that vision's about this stay left, shift left, 10x, and I'll explain that in a second. We think that's then enabled by digital technology in all of its forms. So we know that's apps, we know that's wearables, and you're going to hear more. Zhao's going to be coming up to talk afterwards as far as where wearables are at. And what that does is creates that shared value, particularly in terms of well-being, welfare, and actually the whole concept of wealth as well, because we can both save money and make money with that approach. So this is not wellness because it's just a good thing, it's because it's actually a profitable thing, both for us personally and for society in general. The collaborative ecosystem, this is just a diagram to say who has to collaborate. It's got to be all the stakeholders, of course. And there's a microcosm in this room, just with Bethan doing a little bit of a litmus test of who's in the room, of who is around. We need all of those people to play together. Startups, universities, even startups that have yet to happen, yet to come about, selling into gaps in the marketplace, hospitals, other innovation centers, primary care, work that's in the Creative Commons in other industries, for example. Government ecosystems, Bethan just talked about in detail, patients themselves, and even individuals. We see a lot of innovation coming even from students, and not just students in universities, but students in colleges, pre-colleges and at school. There's a lot of projects going on in school environments that are thinking about issues from a wellness perspective. We need to capture their voices. So that's what this is about. A lot of this has been going on in Ireland. I'm sure Martin would have said more about it. But again, there's literature that you can look at. Enterprise Ireland, and this is not a bad slide just for showing how their ecosystem is currently working. You can see just the sheer range of organizations, some of which have got US brand names on here you'd recognize, that are inherently involved in this initiative in an island context. Ireland's a nice microcosm. Ireland's a 5 million population. It's very tight just in terms of being able to do things, maybe go a little faster. But look at the breadth just in terms of that ecosystem, all working together in terms of this whole wellness side agenda fundamentally. So what is this shift left and stay left? It's based on the quadruple aim. So what we're trying to do in terms of the shift left side of it on the far right there is to move our activity away from emergency care and elective care, much more to prevention and proactive healthcare. So what we want to do is try and move our focus, our attention, our money, our investment into issues such as lifestyle, nutrition, screening ahead of time, monitoring and scanning, better interpretation of genetic data, better understanding of environmental impact, immunization, something we've seen a lot in the pandemic in recent times, and how much that changes things and how desperate we all became around making sure the immunization process worked. So what we're doing in all of this is moving our dollars, our time, our energy massively to the left, to all those things you see on the left, and making sure that the quality of what we do, the quality of care, quality of life, and clinician experience is on that side more than it is on the emergency side of things, where our current cost of care is mainly spent. Again, in an island context, we've got a lot of organizations looking at how they move themselves into that space with tangible strategies. Ones, again, you can read about. We've got background data on. We can talk about more at the end of this session. And it's reinventing a lot of the way that healthcare is delivered through those organizations. And again, you can see they're quite different from, say, the scale of a Medtronic or a Roche, for example, versus Dublin City Council, who's trying to do this in a fairly major city in Ireland, for example. Curley's law, as this has been coined, what this all leads to potentially is using kind of startup thinking and nomenclature, is that we have the potential to create a 10x better future. And what does 10x mean? Because it's one of those nebulous phrases. Potentially, we can be 10 times faster, we can have 10 times lower costs, or we can have 10 times lower volume, particularly in terms of people coming into hospital settings, acute care, with sickness issues, for example, because we're heading those issues off at the pass. So we can be better at, on the left-hand side, diagnosing rare disease or the idea of a particular chronic disease ahead of time. Or we can have, virtualization with technology. We can lower admission rates as it relates to things like cardiovascular disease, for example. We can certainly make better use of our bed capacity and maybe ultimately reduce it because we've got less demand for it. So this is a nice iterative loop if we get the equation right in terms of what we're doing. So this is called the Manifesto, the Manhattan Manifesto. This is the name of the project. And it's evolving as we go. It is a discussion that takes place internationally in terms of initiatives that are taking place. It's convened into the United Nations Summit, which I think is in September of each year. So there'll be a whole update coming on later this year just in terms of where the initiative goes and what it's doing. And giving it further impetus and giving it further funding so that we can push this even harder than we are now. Of course, that needs to make sure that all the stakeholders are enabling this, and Blethen covered that, I thought, well in his last presentation. So government needs to come to the party because we know there's lots of issues that inhibit this. I mean, if we're profiting from a sick care system, we need to start creating environments in which we're profiting from a wellness environment as well. So this work is continuing and ongoing. And that's because you couldn't see it very well in the last slide. These are the areas that are mostly enveloped by the initiative, by the Manhattan Manifesto, where people are at the center of care. So the big shifts as far as this are concerned are big shift to consumer health, big shift to care at home, which we're starting to see even here in the US, but it's giving it much more impetus just in terms of going away from centralized hospital care into more distributed care and virtual care, leading to thriving people and families, hopefully, that stay well for as long as their lifetime as they can. This concept of health span getting greater and greater, not just about longevity, but about having long health spans also. There are some subsets that I won't cover in the way that Martin would have done because there are unique challenges. These are just a couple of them. Women and girls accessing healthcare is one example. We have a whole bunch of health equity issues generally in that space. And just to end on a quotation that Martin included, and I like this quotation, but in an unstable and complex system, small islands of coherence have the potential to change the whole system. We're not pretending that at one level a shift to a wellness side equation, even using this model, is easy. We're trying to create small islands of coherence where we can see this working. It will credential itself and allow others to then emulate that and show that the model works. And it's really that iterative loop where we're seeing the 10x actually starting to work in a measurable way. But that's that.
So at this point, we're privileged. Rich Scarfo, one of the two people behind Health and ViVE. I feel like I should get up and sort of ask him to come on down to the stage in a sort of
Swap seats and you can sit
an
over there.
artistic fashion.
No, I
but
think
I'll
I
just
will
ask
go
him
there and then
to join us.
I will go there.
Okay.
Rich.
Okay, so I think it falls to me, Rich, to ask you a few questions from the audience. So, Rich, maybe first we can, at the podium maybe? Okay.
No, the microphone for Rich, yeah?
Let's give that to Rich.
Yeah. Switch the slide. If you put the next slide, maybe.
We can do that.
Yeah.
There we go. A nice picture of Rich there as well. So Rich, perhaps you can tell our audience just who you are and how you got involved in event management generally, as you are clearly in charge of this whole event here in ViVE, but it'd be great.
Sure. So, are we on here?
Feedback, isn't it?
Okay. Is that better? All right. Rich Scarfo. I'm president of Health, and that is the company that owns and runs ViVE, as well as Health, our other event. I got involved in this in sort of a very circuitous way. I started my career in technology with Consumer Technology Association, and through a series of things moved to the Foundation for NIH, where I really got involved in a lot of the healthcare initiatives that were touching on both global health as well as public-private partnerships with big consumer companies. So I had an opportunity to bring the two together when we were approached by Microsoft Research to come up with an idea to bring together companies that would be able to assist in bringing what they were calling the last mile of healthcare in developing areas, and it was all focused around mHealth. So that's really how I got into this through a series of things. I moved from the mHealth Summit to evolving that into what we call the Connected Health Conference, and then I moved over to health about 5 years ago. So health to me is really wonderful because it brings together both the technology side of things as well as the healthcare, and really a lot of the companies that we touched on in the early days with the global initiatives, from life science companies to big consumer brands to the provider side of things, the payers. So it was really nice to bring that full ecosystem together at my previous efforts, and then at Health and ViVE. It's really the core of what we do.
Yeah. So Rich, we know we have this big event called ViVE, and that's a separate entity, separate conference to a conference called Health that you also run. Can you distinguish those for our audience?
Yeah, so Health really focuses on the innovation ecosystem. So it has a touch point on really every part of healthcare, and quite a few on the consumer side. So we also have a very large contingent of startups and VCs there, and the idea with Health is really to look at where healthcare is going in its most simple form. ViVE is really about the business side of healthcare, also with a strong innovation thread through it. So this is really about what's happening now and how we focus on operating hospital systems, connecting them with payers. And at this event, what we're finding is that the innovation thread is very important. We have about 600 startups attending and exhibiting this event. And they're all startups that are really looking to touch with hospital systems and payer organizations, and it is something that we were a little surprised at, seeing the turnout from the startups. But the main difference with the event, Health is really looking forward, all parts of the ecosystem, strong thread on innovation. ViVE is really about what's happening now and how to deal with the challenges, especially in the US with what hospital systems are seeing.
Yeah.
We're also a little more focused on health IT here versus a broad range of products and services at Health.
Very good. So we've been talking prior to or during this session about the global connected health ecosystems. Can you tell us a little bit more about the global connected village concept that we've been discussing?
So at Health coming up in October, we've had upwards of 50 countries represented at the event, and around 8% of our audience. That's a growing number. It definitely slowed as COVID hit. It's picking back up pretty quickly now. The idea there is we have a lot of companies looking to tap into the US to meet with investors, to meet with some of the companies that are here, and also with hospital systems. And the investment side for us is probably the biggest piece. So we do look to see that having a significant number of startups. We've also seen at Health country delegations grow as well as country pavilions. So the last event we had about 9 country pavilions. We'll probably have around 15. So the idea is to bring a lot of this together in the Global Connector Village. And we've been working closely with the team here on the stage to bring a lot of relationships that they have to that event. And I also should mention that in addition to our 2 events, we have a new launch, and that would be Health Europe. That will take place in Amsterdam of June of 24. And we have Katie Fryatt here against the wall over here, who will be managing that effort. And the idea is that, we have a lot of individuals and a lot of companies coming to the US for what they can find here. And the networking is good, and, it's been something that's a successful part of the event. We also have seen a significant interest from the European market. We don't believe in running an event for Europe from the US. So we have a team that we've been developing under Katie's guidance that will be taking that on. So we'll have touch points with health in the US, but it will be very much a European event.
So, Rich, maybe I can connect a couple of things. I know the agenda for ViVE for the next 3 days is packed. Maybe you could just run through some of the key highlights of some of the activities, what's going on, and then perhaps what's going to translate in your mind into a European environment, given what you just said about being in Amsterdam next year.
Ooh, that's a lot. Okay, so we have a lot planned the next few days. You know, we have an incredible program starting today with all of our partner programs. These are deep dive programs where they're run by the partners. Something that we've done different for ViVE this year, we have about 600 companies sponsoring this year. That's roughly an 85% increase over last year. And we'll have about 7,500 attendees, which is about a 50% increase. We've decided to take the concept that you see at most shows where you go to a room like this for a session, take all of the stages, and you'll find them on the floor this year. So I think the idea of bringing people together and allowing them to stay in an environment where they can visit companies, network, go to sessions. We also have our hosted buyer program, which is where we'll have about 3,000 meetings with buyers and our sponsors. And we'll have our Funding Founders Lounge where we have about 1,800 meetings with the 450 VCs that are attending this event alone, and our startups. So the idea here is to create an environment that is fun, that has a very strong business foundation, to bring together what we focus on really is the senior executive and C-suite for the attendee, and have companies come here with not a massive presence, but a very right-sized presence. So their focus is not on a stand. It's more on engaging with their customers and meeting new ones. So I think that concept for us started at health. We brought it to ViVE. We think that in year 2, we've seen significant growth. It's we think unprecedented for a show like this. Katie can speak to Europe, but the basic premise of the events that we touch on are really what I mentioned. Curated networking, senior exec and C-suite, using people's time wisely, creating not an event, but really an experience for people, and bringing together an attendee base that touches on all parts of the ecosystem. The one thing that Health Europe will bring together is the focus that health has on innovation, and also the focus that ViVE has on health IT and the business side together in one event. So,
fantastic. Rich, can you just touch on the foundation organization that you set up and what that's doing in the future?
So we launched Health Foundation in 2018, and the idea was really to see how we could give back. As COVID and all the social unrest in the States hit in 2020, we decided to lean more into bigger issues. So we focus on access, equity, and inclusion for our Health Foundation. We have some key initiatives. One is C-Sweetener, and that is for mentorship for anyone identifying as a woman that wants to navigate the C-suite. The mentors are male and female. We have other programs, Tequity, that we just launched, which is has a research council attached to it now. But the idea here is really to see how we can bring a lot of the stakeholders together that we have at Health that are looking to have an impact in the industry outside of just an event. So equity, health equity, and Tequity are our 2 biggest initiatives right now. And you'll see in our ViVE Central on the floor, our Tequity stage, and our C-Sweetener program will be focused there. We also at Health have brought together patients at Health, women at Health, and also health equity. So we try to use the events as platforms for the initiatives, and then the foundation picks it up, and throughout the year, we'll create both programs, content, and networking opportunities so we can continue to help propel these things. We can't do it on our own, but we're lucky to have the events to really help us bring a community together and introduce the foundation to them, and it sort of supports us throughout the year.
Very good. I didn't give Rich any prior warning of this, but we are in Nashville, a pretty amazing health ecosystem. What do you feel about the Nashville market for some of our audience who come from Tennessee and this city?
Nashville Entrepreneur Center has been actually one of our top partners here. They have a pavilion on the floor. It's been an amazing city to work in, and what we like about this city is that we can have attendees come here and not just enjoy the event. We have a lot of things going on prior to the event and after, so I think for us that's one of the key things with Nashville is that we're seeing things that are going on for a period of 10 days in Nashville. So that's good. The other thing is the Entrepreneur Center has been very helpful in bringing a lot of the local community to the event, and that's always important for us. And then for our international attendees, there are a lot of off-site visits happening around their time here with us. So for us, you know, we have other cities we're in, like Las Vegas. Yes. It's a little bit different. And but having a built-in healthcare community, and the innovation week or month that's going on right now has been actually really amazing. So we've seen a significant number of attendees come through our partners at the Nashville Entrepreneur Center.
Very good. Yeah. Well, we know the health organization has been a fantastic partner of the ECHAlliance. I think we look forward to particularly working together on the Amsterdam event. Of course, we will be there at the Las Vegas event in October. Rich, I don't know whether you can stay around for Q&A.
I think you have far more important things to talk about. I will be around if anyone has them, but you know, you should probably get to your next session.
Very good. Well, thank you very much for your time today.
Thank you all.
That's great. Thanks, bud. So for those of you, this is the last, at least formal session that we're doing. João Bocas is going to be talking to us about the wearables market. So I'm going to advance the slide once more, I think. Those are just slides on Amsterdam. Those are the dates, by the way, for Amsterdam next year. Those are interested in Europe. But without further ado, I think you're mic'd up. João, is that right? So you might need this in that case. So without further ado, João Bocas.
Is it working?
Yeah, that's good.
Fantastic. I want to share my vision with you. My vision is that wearables can change the world. But before I go ahead with my session, I would like to ask you two things. Please trust me on this. I'd like to ask you to stand up and perform any kind of stretch, any kind of short exercise. It can be a burpee, it can be a knees up, it can be a stretch, anything whatsoever. I'll give you 60 seconds, and also you can connect to someone next to you. Say hello, your name, maybe make a plan to connect later. After all, it's a networking event. Beep, beep, beep. This is the 10-second warning. Okay, brilliant, fantastic. Thank you so much for trusting me in the first place. The second item that I want to ask you is, I only have 10 minutes. I don't really have slides. So I want to ask you, no phones for 10 minutes, please. So you can digest actually important stuff that I'm going to talk about and the content. Anyway, first of all, I'd like to thank the organizers, ViVE, and also European Connected Health Alliance for having me. I'm delighted to be here. For those who don't know me, my name is Joe Bocas, aka the wearables expert. I'm also the CEO of Digital Solutum, a leading consultancy in digital health. But today I'm here, as you can see, to talk about wearables. I love the theme, by the way, wearables delivering self-care or a nightmare in healthcare. I give the kudos to European Connected Health Alliance, chose the headline. It's brilliant. It's really brilliant. I want to give you as much as I can in the next 10 minutes. That's my goal for today. So, there are actually 250,000 health apps, and only 20% of them are compliant and are safe, and this is data from Orca. Most wearables have an health app attached to it, as you know. What I really want to talk about is some of the barriers associated with using wearables, and I'm called the wearables expert, but today, just for the sake of this session, I could be called the wearables devil's advocate. And I'm here to kind of challenge the status quo and also give you a reality check around wearables, because wearables bring so much value to healthcare, and they are certainly the future of healthcare, but they also bring layers of complexity, and they also bring more complexity to what is already very complex, which is healthcare, as you all know. So let me share with you, I've done a 159 pages report on health wearables engagement a few years ago. And the 5 top user-related barriers that we came up with, user-related barriers, was the lack of intrinsic motivation. As you know, it's not just about getting a wearable. Many people get a wearable as a gift or a present, but they're not really interested. You have to have some kind of engagement, intrinsic motivation to use it. Why you want a wearable in the first place, what you're going to do with it. So that was the first barrier. The second barrier, which we talked about here prior, was privacy security. People are actually worried about the health data, and there's so much speculation that pharma sells your data and all this stuff. So people worry about their personal data. But Google has all our data anyway, so. And also human errors and forgetfulness. Personally, I've been guilty many times of leaving my wearable on the top of the fridge. And as far as I'm concerned, when it runs out of battery, if you don't use it, there is no data. There is no data, there is no value. And what is very peculiar around wearables is the change of behavior piece, which is really the trick, because the wearables, they don't work by osmosis. It doesn't matter if you just put a wearable on your wrist, you have actually to do the work and also engage with it. And the last thing that we found out was the sense of no value. People get demotivated because they see, oh, what's the point, kind of thing. Now moving on to the device-related barriers, which it's around the hardware this time. And the first barrier that we encountered was interoperability. What a nightmare. Let me say that again. What a nightmare. That's the theme of the session, right? We also encounter battery issues. Most wearables have probably a time span of 5 or 7 days max. Now there are the smart patches that can go up to 28 or 30 days, but it's more in the medical side. Also, the users related that they're bulky or uncomfortable to use, even though now they become a bit more sexier. The main manufacturers are trying to really make the wearables more fashionable now with colors and nice designs and everything. So that barrier is becoming smaller and smaller. Also the lack of personalization. You know, when you get a wearable, and as far as I'm concerned, you'd be very nice if it was personalized to each of one of you, but it's not like that. They manufacture in bulk. And the last item was the lack of guidance and support. As I mentioned before, the trick around wearables is in a behavioral piece. I remember a few years ago, before Google acquired Fitbit, Fitbit actually acquired a coaching company, and there is a reason for that, because they had that gap. They sell a lot of wearables, but all of a sudden, they were not offering a lot of value to the consumers, and also they realized they need to do something different. And the combination of both, that's what really, really works. I can mention many other barriers. Certainly other challenges in the industry include benchmark. There is no benchmark for good practice. It's all new. Also, data standardization. I mean, there is no standards for data as far as I'm concerned. And we have a big issue around accuracy and reliability. And you see, for example, now in clinical trials and also in other studies, we're using consumer wearables with a lot of issues attached to it. Discrepancy in data. If you use a Fitbit, for example, you haven't got out of bed, but you already done 200 steps. If you use a Garmin, it might say 100. So it's a lot to consider. That's what I really want to say. But there are some very interesting and exciting news for all of us. Wearables are here to stay. And as I mentioned before, they truly are the future for healthcare. The global wearable technology market is expanding and to a compounding growth rate to 14.6% from 2023 to 2030. So we are actually using them and buying them. About 25% of the adult population in US has a wearable, and that's a tendency to grow. And wearables really cause so much impact. Let me remind you what happened with COVID-19. It was all about remote monitoring. We couldn't go to the hospital, we couldn't go to the doctor, we couldn't even leave our houses. But a lot of remote patient monitoring companies appear. Great opportunity to deploy wearables, but unfortunately they were not in place, embedded in the healthcare delivery back then. Hopefully we move on now. But it's so much potential for population health, population management, treatment of conditions, diagnostics, diagnosis, and the management of long-term conditions. So wearables are an excellent vehicle to gather meaningful information about the human being. And now I'm going to wind down because I only have 10 minutes. I am special, and so are you. Everyone in this room has a very important role in healthcare. We all unique. Whether you have an organization with one person or 1,000 people, we all play a part. We all make a difference. We all go out every day to try to do our best. I love healthcare because I love people. That's the industry I choose to work in every day. I'll leave you with the final thought. Wearables can change the world, certainly the healthcare world. Thank you.
Thank you. Right, so we get to the Q&A session for the panel now. So this is your chance to ask any question that you want, and we will try to answer it. So the idea is to make this the last session where it's a bit participative. So your chance to ask us anything that you want at all about what are the opportunities outside of the US, anything that you've heard just now. I'm just wondering, okay, so I have an announcement, a personal one. So I am trying to establish a women's health menopause thematic ecosystem. So if you were here earlier. And I like to think that I'm actually pretty knowledgeable about healthcare. But I have to say, about a year ago, I was bowled over by the fact that I had no idea how much discrimination there was against women and women's health services. I had no idea that in clinical trials, almost exclusively the information used is from men. I had no idea that for the mice involved in clinical trials, they're male, which made no sense to me. It also made no sense to me that my experience of healthcare systems, there are a great many women leaders. So I was like really struggling to understand why they'd done this. So in the United Kingdom, where the menopause services are pants, there is a lady who is the co-chair of the task force at Westminster on menopause. And she is leading a campaign, and she's a really interesting lady. She's about 64 years of age. When I first saw her on Zoom, she had pink hair. And she said to me, I'm really lucky, I have problems with menopause, but because I'm an MP, a member of parliament, I can afford to have HRT privately prescribed. But she said, before that, I was a dinner lady, at which point I thought, I've got a lot of admiration for you. You're not ashamed of what you've done, what your job, where your background was. And she said, so I'm trying to change things for all the women who can't afford private prescriptions. So she led an interesting series of parliamentary subcommittee meetings where some famous women in the acting, in television, started to campaign because they were all the right age. And what we realized as the ECHAlliance is one of the things that we do is we do information. We provide information to people. We enable those connections. And we realized that there was a real problem for menopause. And we've done some analysis around Europe looking at countries, and we're staggered by how many countries don't have a menopause policy. France doesn't, Spain doesn't. And it's a crime, really. I think it's criminal. So one of the things we're trying to do is we're trying to create this ecosystem. And what we need, okay, is companies who have solutions, women who just want to get involved, women who've got knowledge, expertise, and want to join the cause. Because that's what it's about. This is about self-help in some ways. So the appeal is, if you have the expertise or you know somebody who does, please reach out to us, because we see this as a global problem, not a problem for any particular country, and we'll solve it quicker if we do it on a pan-country basis. So that's the first ask, and hopefully you can just take a quick snapshot of that if you want. The other thing that we just talked about was the digital themes, the Global Health Connector partnership themes that Carolina talked about earlier on. And similarly, if you have an involvement and interest in any of those, please reach out to us, because we're doing exactly the same thing in terms of connecting people who've got expertise in these areas. For example, McKinsey's have got a really interesting model for hospitals that need to go green, that need to actually reduce their carbon footprint, need to reduce their pollution. So we've got opportunities for people to work with us. And then Africa and India. So for example, the COVID app in India was downloaded 250 million times. So a lot of people can have sort of set views about Africa and India, not realizing that this is the world of frugal innovation. It's the world of being able to actually bypass legacy systems because they don't have the infrastructure, don't have, whether it's hospitals or primary care, and go straight to digital deployment. So there are some interesting opportunities in those markets for businesses that are headquartered in the US. So without further ado, that gives you time for thinking questions. So all I'd ask is that you stand up. You might need to shout. I think I've got a mic, so I'll come down with people. So if you give your name, where you're from, and what your question is. Okay, so I'll come down here. Ladies first.
Just? Awesome. So my name's Shirley. I am from Hypercare. We are a communication and collaboration app based out of Toronto, Canada. And Blood, my question is actually for you. You gave a really great talk around digital legislation in the EU, and it's very, very comprehensive. So what are some I guess, tips or tricks or tangible takeaways for organizations like Hypercare who want to consider expanding into the EU to keep abreast of all the different legislative changes. And for us, resources are very constrained. So what are things we can do to examine our readiness to expand into the EU, or other ways we can consider expansion?
Okay, so the ECHAlliance is fundamentally a route to market. Okay, our ecosystem bases are on the ground doing real things in healthcare. So if you want to enter a market like Spain, we have 7 ecosystems in Spain because it's a very regional, market. It's not just one market, Spain. So it's about looking at our newsletters. Carolina was talking about the projects. That the EU-funded projects are publicly available information, so you can find out what research and conclusions they've reached. The roundtable programs, which I demoed, that's got substantive information in it. You can get involved in some of our events like the Digital Health Society Summit, where we'll be talking about that. And I think when we do that in November this year, Carolina and I are still doing the planning for what the 2 days are, but I think an entire day is the European Health Data Space. Because Microsoft, J&J, MSD want to be able to talk about what it means for them. We'll be showcasing Finland, which is the most advanced European country in terms of provision of health data. But we'll be doing things really practically about, so what data, how do you apply? Can you apply if you're outside of Finland? What does it cost? And then there's something called the French Data Hub, which is trying to do the similar sort of thing. And we'll probably have some politicians talking about what that will mean. So fundamentally what the ECHAlliance does and the ecosystems does is about making the connections, convening as we said, but providing the information that's there. We have consulting services, so some businesses will come to us and talk to us about, well, how do we tackle this? And once, we're a membership organization, so once we've got members, we'll look out for opportunities, because that's about the convening and making the connections. So hopefully that answers the question. So if you hand the gentleman.
Hi, I'm Dave from Brace Technology in San Francisco, California. And so what you do at the ECHAlliance is great. My company does that with a few clinics in Africa to build low-cost telediagnostics. And we also provide education training to upskill the medical staff there, because there's very few MDs, right, compared to other countries. But the challenge we've encountered is that we have great technology, we're making it free, but the recipients, they're already inundated. They're burnt out, just from the work they do. There's a lot of cool technologies popping up. So what have partners in ECH done to overcome that adoption barrier of just a lack of bandwidth?
I think that this is definitely a universal problem, a universal issue that we are dealing with, that we are also, and we have to be mindful that the digital transformation is not bringing more technology, but actually making sure that more people use the technology. So I think that our mission and what we want to also bring to the world is to make sure that we work in this ecosystem to embed the digital tools, the digital solutions, and the digital health within a system. So it's not only bringing more of the tools, wearables, systems, IT platforms, and so on and so forth, but actually to address the certain needs of the people. And of course, we know that there is a problem of the burnout of the healthcare staff. And we tell them also, as we saw on the shift left, stay left, like we know that ultimately bringing the digital technology to health system should reduce the stress of the people, healthcare professionals, should improve the outcomes and should save us a lot of money. But when we don't do it right, of course, we are just hitting the wall, and we're getting people who are like, as I showed also on this uncertainties, like, are people empowered or not? So we are actually like not helping them to be empowered with the digital technologies. So, of course, I think that this is the discussion we can go on and also share a lot of different examples from different countries and different organizations. But I think that what we promote and what we also motivate our partners to is to look at this from this ecosystem level, to really work together across the sectors and to bring everyone to the table, also the healthcare professionals. So if I bring you the solution first, I will let's work together. If you need the solution, how does your day look like? When will you be able to use it, and what kind of support you need? I'm sure that you are doing this as well, and of course, if we can somehow help you with that, then we're happy to do so.
Saying that the key thing about the ecosystems is it's all stakeholders on the ground. So one of the advantages of working with our ecosystems is that you are dealing with the parties, the partners, that you need collaboration. So if we just try to go somewhere as ourselves and we don't have any local connections, then you're going to hit problems around capability, capacity, time. But if you're dealing with, let's say in Africa, the African Business Federation, and all the ministries, you've got the links to be able to work out how do you best assist with whatever the particular project is. So I think that's one of the advantages that we bring and our network brings, is those local connections that you can collaborate with to deploy.
Can I add one other thing as well? We haven't had the time this afternoon to unpack even the 5 things you see up on here. If I just take one of them, like digital skills and workforce, that means many different things, of course. So we're thinking about clinicians in the mix, we're thinking about patients in the mix, there are subsets of those. So just joining that ecosystem alone deals with issues like burnout, or issues like recalcitrance on the patient side of things, or the fact they're in a rural population and don't have access. So we haven't had time to do that, but I think by joining these ecosystems, you start to get input to what you're trying to achieve, even if your goal is activation, for example, on the patient side, and making sure, as Joe was talking about with wearables, it's not just buying the technology, it's using it and using it again and again, and getting the real benefit from it.
Yeah.
Hi, I'm Dave Delesk with Embrace Prevention Care, and I love the stay left, shift left. My question is around that, what are the best demonstrated practices that we see on a global basis for countries that are already there, and things that we can replicate rather than having to start from scratch?
Great question. So we didn't have time, but the shift left, stay left is about 10 years old at least. So it's a Finnish concept. And so Finland has, in restructuring its healthcare, so it used to be that every hospital was run by a mayor, okay? And I forget how many, was 450 or maybe more, okay? So when I first saw it, that's what the model was. And then they've shrunk it to about 12 to 14. And part of that is then about being able to rationalize the hospitals, so make them, because it's really unpopular with people. So who knows what a hot and cold A&E is? No? Doesn't mean anything to you? Okay, cold A&E, Monday to Friday, 8 a.m. to 5 p.m. Hot A&E, Monday to Sunday, 365, 24 hours. What's the other difference between these? A hot A&E is in a tertiary hospital, a teaching hospital. The public in the UK, for example, think if you have a car accident, whether you live or die, is how near you are to the nearest hospital. Okay, you have a serious car accident, 2 things happen. If you're in an ambulance, they drive past all of the smaller hospitals to get to the tertiary hospital where you can survive, because your chances of surviving are the expertise beyond A&E. If you're really seriously injured, you're in a helicopter and you're helivaced to that particular hospital. The public don't understand that. So they do not know what this model looks like. They do not know why it's not a problem if their hospital is downgraded to a cold A&E. Okay? The trouble with healthcare is there's no honesty about healthcare, okay? Most countries pretend that if you're ill, you can have whatever it takes to treat you, which is bullshit, okay? Because we can't afford it. Nobody can afford it unless you're super rich. So politicians are never honest, and I worked on secondment in the UK, so I worked for the British Prime Minister at times. So I actually, and he had a majority of 136, and he couldn't be honest about some of the things. So this is a problem everywhere in the world, which is why we believe in the ecosystem network and its disruption. And you make a perfectly good point about you need to demonstrate what this means. And that's why John was saying, in the next UN General Assembly in September, one of the things that Martin and others have got to move from is the concept and an awareness campaign about what we're trying to do or what they're trying to do, and actually illustrate with case studies about how you do this. The UN are very interested in it because they promote policy, but they want to see implementation across the globe. So actually it's going to be really interesting. And for us, we're very interested in the fact that it's much easier to deploy this model in the developing world, where you don't have the legacy systems in terms of hospitals and primary care, than it is in the traditional systems where they are heavily reliant and focused around the hospital model and the primary care model. So I think that's going to be one of the things in the next couple of years where we need to make sure that the examples are in the public domain, easily accessed. I mean, I don't know whether other people would agree with me, but one of the problems I find is that there's an enormous amount of research undertaken, okay, but nobody knows it's there. And for those of you who know Joe Caveda out of Boston, he's now the editor of Nature's Digital Medicine. And he gave me a statistic recently which terrified me, which was that most publications are only read by 4 people. So if you just think about what that means. So the big problem here is, how do you get these messages out? How do you show what best practice looks like so people don't reinvent the wheel everywhere? So it's a big challenge. We like to think that the model that we've got, it isn't the complete answer at all. We wouldn't pretend it is, but it mitigates some of these challenges.
One thing to add to that, your question, Dave, I think you know the answer to this is that there is not one country that's got a lock on best practice. So yes, there's going to be parts of what the Finns have done, parts of what the Irish have done, parts of what the Australians have done. In microcosm, I was in India last October. For example, their rollout of 5G, for example, is ahead of ours here in the US in about a third of the time, because there's no legacy legislation to stop them doing that. So they're going to reap all the benefits of that. So if I were thinking about 5G in particular, then I'd probably look to the Indian model in terms of what they've done and how they've done it. So I think we have to surface best practice in order to adopt it, as Blethen was saying.
So I have the unique perspective of being an American citizen who lived for 15 years in Switzerland. I was Switzerland's first entrepreneur in residence for about a 1 billion franc early stage life sciences fund. They had no idea what an entrepreneur in residence was. You could argue they still may not know what that is. But the great perspective for me was how much, this is what Bledden was getting at, how much information gets packed inside a cultural cocoon or a shell or whatever you want to call it. And you have to come to conferences like this and talk to people, and it shouldn't be, oh, you live in Europe, I live in America. This is we're talking about people, patients, healthcare, and that's very universal. It's something to say it, but it's quite another to actually capitalize on it.
Yeah, agreed. Well said.
Yeah, I couldn't agree more. I mean, the lawyer in me is quite controversial, so some of you may have already got a flavor of that. So I do not understand, for example, why a woman who has breast cancer in London is treated any differently in Manchester, is treated any differently in Edinburgh. I can't get that, okay? But I simply can't get that the treatment, the pathway, is not universal around the world. apart from when the genomics are different and there are different reasons, why to God would there be different things? When I first got involved in healthcare, Tony Blair wanted to revolutionize elective care. And we realized that if there were, I'll just talk about hip surgery, if there were 250 hip surgeons in the NHS, there were 250 ways to do the operation. Like, as though no one had ever heard of process engineering. Driving better quality, driving down cost. And it was like, why is this there? And in law, when you buy and sell a house, that used to be a cash cow for lawyers 50 years ago, and it subsidized other work. Today, it's not done by lawyers, it's done by secretaries and paralegals. And it's not because the work is any less intellectually challenging, it's just what the market's done. And what's happened in healthcare is substantially doctors have been able to resist process engineering and change because they actually play the card of safety. And there are times when they need to play that card, but there are also times when it's just resisting process engineering and change, which is in our best interests as patients. So I totally agree with you. So I'm going to use my prerogative and give one last question, or if there is none, I'm going to say thank you very much. Really appreciate you spending your Sunday afternoon with us. We did say at the beginning, for those of you who joined late, that we've got the glass bowl with business cards. If you want to talk to us afterwards, we're not disappearing straight away. If you want to reach out to us, because we're all here for the next 3 days, please use the ViVE app, and you can reach us there and arrange to talk to us if you've got things that you want to do. So thank you very much. I really appreciate you being here. It's a privilege for us. Thank you.
Thank you.